Hi. Okay, so this is a new video created for you guys for just for today. Previously, all the videos you've been watching were recorded a while back. But this one's a new one for you. I'm going to give you a little bit of a quick review of the upcoming exam, which will be opening up on Monday. Now remember, the exam is open for all 5 days, Monday through Friday. You can use one note card, 3x5, both sides, and it will have 30 questions, just like the first exam. Hopefully, unlike the first exam, this one's going to work. I really hope. I still have no idea what happened. And like I mentioned in the announcement, I really have no way of salvaging that exam. So we're going to just wipe it clear. It never happened. What I am going to do, like I mentioned, I'm just going to reiterate it, sorry I got an itchy nose, is each of those learning plans I'm going to carry over onto the following next 3 exams. So instead of the next exams having 20 questions, they're going to have 30, with 10 questions from an earlier learning plan. So the upcoming exam will be on learning plans 4 and 5 and 1. Next one will be on 6 and 7 and 2, and then 8 and 9 and 3. And I'm telling you that right now so that you know exactly which learning plans to review. And for each of those learning plans, I will record one of these videotapes or video whatevers just to quickly go over some concepts. And I'm just going to quickly whip through these. I'm not going to spend a lot of time on any one topic. If you have questions, shoot me an email. But I did this for the face-to-face group. I'm going to do it for you too, so you all have the same benefit of my preparations or your preparations or whatever. So the first learning plan is on quality care, achieving quality care. And just some things that you really need to know about. Understand always what's the idea of a root cause analysis. What is the root cause analysis? It's the very basic bottom line trigger for everything that has followed. If you don't know, like everything, if you don't know what is truly causing the problem, you can't fix it. We're going to, quality improvement. QA, TQM, risk management, Six Sigma, those are all different names for the same thing. It's always the idea of looking at what's gone wrong, and then what can we do to fix it, and always looking to get better. Even when things are good, you still want to get better. So that's continuous quality improvement. Very important to reduce bad outcomes, and more importantly, honestly, more importantly than reducing bad outcomes is making the good outcomes even better. The nurse's role, is we are not decision makers as nurses, and yet apparently we cause most of the problems from the doctor's point of view. But why do nurses have such a hard time with using evidence-based practice in quality care? Well, it's because nurses have a hard time asking the questions and creating the right question, that PICO question. And if you can't ask the right question, you can't get the right answer. It seems so simple, but that's the problem. And nurses, well, how much extra time do you have in a day to go out and research? Me too. That's the problem. We don't have the time. If we had the time, nurses would be up to date. They would research, because I believe that all of you and all the other nurses want to do good and want to do better. We just don't have the time to get better. And that's really frustrating from my perspective. Structure, process, outcomes. Structure, process, outcomes. Got to know that. Structure, it's the stuff. So in this case, the upcoming exam, the structure is the exam. Okay, the questions are the structure. The process is taking the exam, and the outcome is your grade. So make sure you always understand structure is something. A process is an action, and the outcome is course, the end result. Lost my place there for a second. Sometimes I click the wrong buttons. Make sure you understand the idea about key outcome indicators, sentinel events, never events, the difference between an indicator and a metric. An indicator is what you're studying. The metric is the measurement. So you could look at rates of ventilator-acquired pneumonia, VAP, or catheter-acquired urinary tract infections. So the VAPs and those CAUTIs, that's the indicator. How often they occur? The metric. You'll be using indicators and metrics all the time. Who determines the goals and standards? Well, it's the ANA, it's Joint Commission, it's that whole list of agencies. But we need to understand there's many influences on nursing, and we try. In other words, nurses have a lot of masters, and we try to make sure we meet everybody's goals. So what happens if there's a problem? If there's an error, we have to fix it. Maybe. If let's say suddenly I'm working with a clinical group and everybody is drawing up insulin drawing up insulin incorrectly. Everybody. Well, if everybody's drawing it up, likelihood is the root cause was an incorrect teaching. But if only one person draws it up incorrectly, that doesn't mean I have to go back to the school and say, we need to change our teaching. I have to work with that fluke. That's just one person. So just because there's errors does not mean that the system is broke. It might just mean one thing. But if a lot of errors of the same sort happen, there's a system-wide problem. Six Sigma is all about reducing the errors to a really low rate. It comes from the auto industry, and it's the thing right now, along with lean in industry and making things more efficient. That's really all you need to know about that. DMAIC, that is the define, measure, analyze, improve, and control. So define, of course, is simply what is the problem, what is the indicator, who's going to be working on it, deciding, creating the team. The measure phase is measuring the problem, getting the key performance metrics, and looking at all those things. You measure the problem first, and then you look at solutions. Analyze phase, that can be challenging. You have to look at all the numbers, all the data, and then determine what is really the problem and what is the potential solution. The indicator or improve phase, that's when we put the changes into effect. We work on finding that answer and then implementing it, and then the control is probably the hardest phase because it's the last phase and it has to stick. Control phase is when you standardize the new process or procedure, you codify it, you put it in policy and procedure manuals, you teach everybody, and you make sure everybody does it the correct way. And in doing so, we're making people change habits, and that can be difficult. Remember, most of nurses use all of their skills and knowledge that they learned in nursing school. So the likelihood is all of you taking this class right now, in 20 years, you'll be working exactly as you were taught in this school, or very close to the way you were taught in this school, even if things change around you. That's why the control part of DMAIC is so difficult. So evidence-based nursing practice, it's research utilization is another term for it. Less than 20% of medical practice and even less nursing practice is actually supported by evidence. A lot of it is supported by, well, it's worked for me in the past. We've always done it this way. Why should we change? It works. You know, if it's not broken, don't fix it. Well, just because something's not broken doesn't mean it can't get better. Nurses depend on what they learned in nursing school. They don't have the time. It isn't that they don't bother, they don't have the time to learn new things. They also don't necessarily like to research. How many of you on your summer vacation went out and did some evidence-based research for nursing? Probably not many of you. I do it for school because I have to do it for school. Honestly, I wouldn't do it otherwise. That's me. It can be difficult to interpret and understand research reports until you get good at it. It's a foreign language, and just like any foreign language, it takes a while to get good at it. So we need to look at different, understand how to do the research, how to write the question. That's the key. The key thing is nurses need to know how to ask the question. And because they can't create the right question, they really have a hard time getting the right answers. So the PICO question, of course, patient population, the intervention or interest, the comparison to the comparison is the control group, and then the outcome. Levels of evidence. There's many different levels of evidence. Meta-analysis, where you grab many different research studies and pull them together and then analyze all the data, is the best. Expert opinion or case reports is the least valuable, but not. It's the least valuable, but not. It doesn't have no value. Everything has value. Every bit of data is important. It's just you have to make sure you understand the difference between a few nurses on the floor saying this is how we should do things versus a double-blind controlled study that used 1,000 people. The two nurses on the floor might be exactly right, but they don't have the research to back them up. Guidelines.gov is a great place to start looking for research. You always want to go for research. When you go for research, you want research that is validated by peer review. You want to avoid opinions. You want solid evidence. Guidelines.gov, everything there is already evaluated to be valid and peer-reviewed and evidence-based. So guidelines.gov is the place to go if you want research. Ovid or CINAHL, you can find things there, but you can also find a lot of other things there too. So if you don't look in the right place, you're not going to find the right answers to your question. So guidelines.gov, excellent. AHRQ, Agency for Healthcare Research and Quality, is what sponsors that. Nursing journals can be very good, but remember, we need research journals, not Nursing 2014 or even AJN, American Journal of Nursing. Those are good magazines, excellent magazines, and they publish research, but they usually publish synopses. They don't publish the entire research article. And for true and valid information, you need to go to the source. When you read a research article, make sure you are that it applies to your practice. If you are looking on, if you're a pediatric nurse and the research was using nothing but the geriatric population, it might be valid, but probably won't be. So make sure you understand the sample that was being done. Look at positive and inverse relationships. Positive relationship. I can't think of. Oh, here we go. Positive relationship. This is actually used in class. The more you drink, the drunker you get. Positive relationship, not necessarily a good relationship, but that is, one goes up, the other goes up. Negative relationship. The more time you spend studying, the less time you have to go out and party. or to spend time with your family. That's an inverse relationship or a negative relationship. The change process, 3 steps: unfreeze, stop doing the old pattern, then change. You're going to make whatever changes need to be made. You're going to educate people. You're going to get buy-in. You're going to explain the why. Why are we doing this change? Not just you're doing it, but explain the rationale, the benefit of making the change. And then when people start buying in, you have to refreeze. Try to make it a habit. And again, that is the hard part. Stopping an old habit, difficult. Changing things, difficult. Keeping things changed, always a challenge. Errors, you need to understand errors could be diagnostic or treatment errors, but they are important to always track. If you're not willing to report an error, that suggests that maybe you're afraid the error will be used against you, and it shouldn't be. It can be, but it shouldn't be. When an error happens, even if it's a near miss, which means nothing happened, nobody got hurt, but it almost happened. For example, let's say you're going to pass a medication and they need 4 units of insulin, and you turn the pen and you accidentally click at the 8, and you're getting ready to give it, but before you give it, you notice, whoa, I almost gave too much insulin. That's actually a near miss. It's not an error, but it could have been. So being willing to acknowledge that, admit errors, and report them indicates that where you're working actually is supportive of acknowledging those mistakes and not being punitive and punishing people. Again, root cause analysis, what is actually causing the problem? You don't always have to do a root cause analysis when an error happens. But when errors are consistently reported, if you consistently see the same errors, you need to find out what the root cause is always. So that basically is a very, very brief synopsis of Learning Plan 1. I did not cover the whole learning plan, obviously, but I went over things quickly just to give you kind of reminders, because that was a few weeks ago that we talked about. Let's talk about Learning Plan 2, Learning Plan 4, Economics. And again, we're going to go through this very quickly. You need to know intrinsic and extrinsic factors. Intrinsic factors are things within the population or within the person. Extrinsic are things coming in from the outside. So the aging population, the growing baby boomer population, healthcare demand, people wanting the best medicines because they see it on TV, that's intrinsic. Extrinsic is, in Green Bay there are 11 different MRI machines. Prescription drug costs are extrinsic. All costs are extrinsic. So again, the definition of economics is the allocation of scarce resources. So how do you spread money? That's the scarcest of resources. I'm just finding slides here that we need to talk about. Code of nursing for ANA. The ANA code for nurses. Nurses provide care without consideration of social or economic status. And we should always do that. It should matter who your patient is. It could be the local CEO, it could be a Packer player, it could be a homeless person. They should get the same level of care. Do they? Probably not. Probably not. That's not right, but that is, unfortunately, life. I hope we all try to act correctly, but understand that not everyone acts the way they should, and we need to temper our frustration at the system, because we can make changes, but individually it's slow. we shouldn't stop trying to change, but don't burn yourself out if you see things that are going wrong and you want to change it, okay? The payer, the idea of a payer is the person that actually pays the bills. If you have, let's say, you go out to buy your groceries, you are the payer. If you are using food stamps or the EBT card, actually the government is the payer. You go for, if you have a car accident and you get your car repaired because you have car insurance, your insurance company is the payer. Payers have different rules. Sometimes they need pre-authorization or pre-approval. They use utilization review, which is looking backwards. Was the decision to pay correct? And again, those are jobs I used to do. Marketplace can have that's called payer allocation. Should they pay? Will they allow it? All that. Marketplace allocation is if there's competition. Multiple hospitals in one city can drive costs down. So that would be a marketplace allocation. But it's very difficult to start a hospital. So there's a barrier to market. There's no price competition. Holy Family doesn't have a reader board saying, "Hey, prostate exams half off today," or buy one prosthetic leg, get a second one free. They don't do that. They don't advertise their prices. Nobody really knows what it's going to cost until after it happens. So that's a marketplace allocation. Rationing allocation doesn't happen a lot, but rationing is when there's limited quantities, who gets it? And that decision is always challenging. It raises a lot of ethical questions of who makes the decision and what criteria do they use. Budgets. 3 kinds of budgets: capital, operating, and personnel. Personnel being the largest single budget you can work with. Capital budgets are for long-term expenses, so buildings, hospital wings, MRI machines, usually things that are very expensive. A lot of times it's $5,000 or more. And a capital budget you usually plan a year or more in advance. Operating budgets are things that are used on a day-to-day basis. So in a hospital, operating budgets would be things like supplies, linens, heat, light, taxes. So that's all operating budgets. Basically, it's the stuff you need to have. You just need to have around in order to stay in business. Capital budget, you don't need a capital budget unless you're going to buy something big. Personnel budget is people and everything related to people. So it's salaries, it's vacations, it's health insurance, and any other benefits. It is paying for their ongoing CEUs or paying for school reimbursements. That's personnel budget. We always want to make sure we are fiscally responsible, both to the patient and to our employers. We want to use resources wisely. If you're going in to do dressing change, bring in what you need, or maybe what you need for your shift and the next shift. But don't bring too much in, because obviously if it goes in the patient's room and they get discharged or they die, for heaven's sake, you don't want that. But if they do, those supplies have to be thrown away. So be time efficient, but also be fiscally responsible by not squandering. Here's something that I focus on a lot with my students. Let's say they're on maintenance. I have maintenance fluid of D5.5 with 20 of potassium. And it's running at 150 an hour. The bag has, let's say a bag has 100 mils left in there. Well, that's going to run out in about 40 minutes. Some nurses will just, when they have a chance, they'll just change the bag because, we're going to need it no matter what. Personally, I wait until it's almost empty, because one of those bags is $150 to $200. That is, I don't know about you guys, but for me, it's a lot of money. So what happens if you spike it and then you get a phone call from the doctor saying, change it to lactated ringers or stop it altogether? If you had waited on the first one, you might have saved that patient that large charge. And if you're going to spike a bag of saline, let's say the doctor orders a 500 ml bolus because the person has low blood pressure. Hang a liter. Just hang a liter. Don't hang a 500 ml bag. They have them. The reason why I say hang a liter is a liter bag of saline is the same price as a 100 ml bag of saline. You are not paying for the saline, salt water. You're paying for the processing of the bag itself, and the sterilization and the transportation. So if there's a chance that you'll need more than 500 mils, hang a liter. It's going to save you time. It's going to save money. So that is the first half of Learning Plan 4. Second plan is healthcare delivery and types of healthcare organizations and what goes on in those organizations. HMOs and PPOs, this is an important concept. You have to understand the difference between HMOs and PPOs. HMOs involve gatekeepers, which try to minimize you from using the system. HMOs, the employer pays per month per head. So the employer pays, let's say, $1,000 per employee per month. That's it. That's all they pay. The HMO gets that $1,000 per person, but if they spend $2,000 per person that month, the HMO loses money. The employer does not pay any more money. The employee pays no more money. So there's that very definite amount it's going to cost. But to get to see a cardiologist, you have to go through many layers, let's say. Whereas in a PPO, if you want to go see an orthopedic surgeon, you just make an appointment with your orthopedic surgeon. No gatekeeper. But in a PPO, you're going to pay co-insurances and co-pays and deductibles. In both situations, in both HMO and PPO, you have networks. And you can go anywhere. You can see any doctor inside of networks or out of networks. It doesn't matter. That applies to HMO and PPO. You can go see anybody. But in an HMO, if you go out of the network, the HMO pays nothing. You're responsible for 100% of the cost. In a PPO, the PPO insurance company will still pay if you go out of network. They just won't pay as much. So there'll be more responsibility on your end. So that's a big difference there. You can go anywhere. If you go out of the network on an HMO, there's no coverage. On PPO, there's just less coverage. Integrated healthcare delivery, that's the Walmart of healthcare. You go to one company or one organization, and they provide everything. Aurora has clinics and pharmacies and home health nurses and hospice nurses and hospitals and rehab centers. So Aurora is almost totally integrated. They don't have nursing homes. So one-stop shopping. It's just an umbrella of one corporate umbrella that provides everything that a person could want, which provides continuity of care for the patients. It makes the doctors easier because they can access all the records. It does provide cost savings to that corporation. Also, it keeps people coming to their company. So that's very nice. Case management supports managed care. It ensures it's coordination of care. That's the big thing with case management. When you have a case manager, they make sure that the right doctors are being seen, the right procedures are being done, and there's coordination and communication between everyone. It's planning and coordinating and organizing. That's case management. Now there's also clinical pathways and disease management. Clinical pathways, also known as care maps. Clinical pathways are used in hospital to get the person back out. They are standardized based on time, and they are multidisciplinary. So a care map or a clinical pathway will list physicians and nurses and respiratory therapy and dietary and therapies, and it will stay at, hour 0 is when the person is admitted. Hour 1, you should be doing this. Hour 2, doing this. Hour 3, doing this. if there's a variance, if let's say at hour 4 you should be extubating the patient and suddenly his heart stops for whatever reason, that's a variance. That's going to make you defer to maybe another care map or set you back on the care map. But it's time-based. And it does that so that everybody with that condition is treated the same. Now, if a person has heart disease and is diabetic and is overweight and has something else, they will layer care maps to make sure that that person is being treated appropriately for all those conditions. Disease management is used pre-hospital. It's used outpatient. It's designed to prevent somebody from coming to the hospital. It's nurses. Nurses usually calling their patients. If a person is the asthma disease management, you'll have a caseload of people who have asthma. And you might call them once a month to ask their peak flows, and are you using your medications, and how often do you wash your linens and vacuum the floors? Do you have hard surface floors or carpeted? And they do everything possible to keep that person from getting in the hospital. So clinical pathways in the hospital to get them home or to another level of care. Disease management while they're at home to keep them at home. Both are designed for standardized, good patient outcomes and to save money. Money drives everything. Okay. Evidence-based practice, we kind of just covered that in the first care plan. It's kind of why I put this care plan or this learning plan right after evidence-based. There's healthcare organizations that are centralized, which has strong, active management. There's decentralized, which is more independent. Home health nurses are decentralized. And to a large degree, ERs are decentralized. The nurses there operate off protocols and habits and learned knowledge, but they also act on their own. So that's decentralized. And then, of course, there's organized around a product line. So you could be working at a surgical center or an eye surgery clinic where you just focus on eyes. That's a product line organization. Client safety, we always want to make sure healthcare is safe, effective, patient-centered, timely, efficient, and equitable. Difference between effective and efficient. Effective is outcome-based. Effective is how good is the outcome. Efficient is how fast do you get to the outcome or how inexpensive do you get to the outcome. Timely, of course, is time. Equitable is everybody's treated the same way, regardless of the person. Patient care delivery models. Total patient care or private duty. You are there for your entire shift and it's just you. You do everything. You provide medications, you bathe the person, you walk the person, you feed the person, you do whatever. It's just you and that person, or you and two people maybe. Commonly seen in critical care units, intensive care units, women's health, sometimes in ER would be total patient care. But like I med-surg for, you'll never see that. Home health nursing, total patient care. Functional nursing, that's where everybody on the team has their role. One RN is nothing but assessments. One RN is nothing but medications. One person is nothing but ambulating, feeding, and bathing. Everybody has their role. Good side to that, you get very good at that job. And if you're assessing people, if you assess everybody, there is consistency in their assessments. That's good. If you're listening for lung sounds, you get very good at listening to lung sounds, and everybody has their lung sounds equally graded. Downside, if the assessment person goes on break and the other nurse is available, if something needs to be assessed, they're not going to be as good. The other downside, it's broken up care. For the patient, yes, they see a lot of people, they have a lot of caregivers, but they're not sure who to ask for when they turn their call light on. So it's very, very choppy care. A lot of nursing homes are functional. Team nursing, similar to functional nursing, but not quite. In team nursing, you might have an RN or two and an LPN and a CNA. The RNs will divide up the team with the LPN, and everybody will be assigned their caseload. So all the RNs will do assessments, and all the RNs will pass meds, and the LPN will pass meds, but only to their people. This gives a little more continuity for the patient. But when you do that, you lose the ability to become specialized in your specific skills. Primary nursing is where one nurse for 24 hours is responsible for everything. You coordinate all the care. So you have your caseload or your patient, however many it might be, and for 24 hours, you're the boss. You have other nurses on other shifts that provide care, but you monitor everything. So respiratory goes through you, and dietary, and physicians, and radiology, and everybody works their schedules through you, so that you, as primary nurse, pretty much know everything about that patient. It's not very commonly used. And then patient-focused care, that's where it's similar to team nursing, except everybody is cross-trained to multiple jobs. So the CNA might also be, well, for example, when I was a CNA, working at a hospital, they did patient-focused care. And as a CNA, I was also a HUC, a monitor technician where I would monitor telemetry, an EKG technician where I would obtain EKGs, and a phlebotomist. So I was cross-trained to 5 roles. In almost every role, though, the RN provides management of care. Different types of management of care, but the RN is always manager. Work assignments, Some states have mandatory minimums or mandatory maximums where a nurse can have no more than 5 or 6 patients or whatever it may be. The problem is they almost never get fewer than that. In California, that was one of the first states to do that, and they loved it at first. Now, they don't take acuity into account. They just say, if the state says no more than 2 patients, you will get 2 patients. They might be both ventilator bound, but you're going to get 2 patients. So it's not always as good as people wanted. All right, that's it for Learning Plan 4. Let's quickly go through Learning Plan 5, Politics and Collective Bargaining. This is going to be a relatively long review, and I apologize for that, but I wanted to kind of just throw this all out in one. Politics, make sure you understand the definition of politics, which is the influencing of the allocation of scarce resources. So economics is the allocation of scarce resources, the spreading of money. Politics is influencing how the money is spread. Again, everything revolves around money. When a nurse is politically aware, they can nurse smarter. They are able to use influence and obtain supplies or staff or whatever because they know how to work the system. They know how to analyze issues. They are able to present possible resolutions. They participate constructively, but they're not afraid to say what they need to say. And that one right there, the voicing one's opinion, is probably, as a whole, nurses, one of their biggest challenges. A lot of nurses are no problem. They'll do whatever, but they don't say stuff. If they see a problem, they don't voice the problem where it can actually do something. They'll complain to themselves, but they won't complain to the people that can make changes. There are there's 5 laws of power, but we're not going to worry about the 5 laws of power. We're actually going to look at the 5 sources of power, which is reward, coercive, legitimate, referent, or expert. Reward power, that's giving a reward. Getting a paycheck is a reward. Getting a raise, getting a day off, reward power. Coercive power, punishing people. Threatening people. If you don't work, I'm going to take hours away from you. If you don't take that assignment, you won't get the raise next year. Legitimate power is power that's conferred upon you based on your position. Your manager has legitimate power. I, as an instructor, have legitimate power. Referent power or mentor power, that's power that comes from somebody else, but kind of like you're basking in the glow of someone else. So if you as a staff nurse are good friends with the manager, and everybody knows that you're good friends with the manager, that's referent power. You're getting power kind of from them because everybody knows that you have the ear of that manager. Expert power is anybody who knows something. You, every one of you as students, are experts. Maybe not in everything, and maybe not every day, but I'll bet you go to the clinical site and sometimes you're able to teach the nurses something. You can look up something, or you know the latest technique, or you have a new skill. You are an expert, even as a student. You can have multiple powers. Me, I have reward power, grades, coercive power, bad grades, or adding more work to you. I have legitimate power. I'm an instructor. I potentially have referent power. If I'm good friends with the president of the college, that's referent power. I'm not, but that could be there. And I'm also an expert. But like you, I'm an expert in some things sometimes. I will be the first to say I do not know everything. I won't even pretend to know everything. You should see me in my pharmacology class. Oh my goodness, I'm the teacher there, but I'm learning right alongside of them. Reward power is the strongest source of power. It motivates people to do things. Coercive power is the most negative power. It can also work though, but it tends to have bad long-term outcomes. Expert power is the weakest power base. It's good. It's a good power, but it's the weakest of all of those. On the other hand, sometimes when your patient asks you a question, you are the most important person with the most important power. Networking among colleagues. Networking is important because it builds power among people. The more people that work together, the better the power. So a network is people with a common group and a common interest. The ANA is a network. National League of Nursing is a network. LCSNA is a network. You're all the same type of person working toward the same thing. Networks are relatively easy to build. They have power, but they only have power when there's a lot of people. A network of 3 nurses has minimal power. But if you get all the nurses in a building, or ideally all the nurses in the city, now you have power. Coalition is harder to build, but much more powerful. Coalition is a group of people that have a common interest, but are not the same type of people. So, a coalition of nurses, doctors, and hospitals would be incredibly powerful and almost impossible to create. But a coalition is only built for one issue. American ANA, that has many issues, and the issues revolve. Coalitions are designed for one thing and one thing only. When that's resolved, the coalitions break down. So, in the election process or politics, there's a lot of things you can do. Get involved, volunteer, talk to people, share your ideas. You can contribute money. It can sometimes become an obsession though. So try not to do that. But if you have to, it's not the end of the world. PACs and professional organizations are different. ANA is a professional organization. It has its own rules. So it does not lobby people. The ANA doesn't lobby. It has a political focus, but only on endorsing candidates for office, and it only evaluates candidates on health concerns. It doesn't matter what they say about gun control or the war in Iraq or whatever. It's what do they say on health. So that's the ANA. That's their focus. Now, the PACs are the checkbooks. They're money. The PAC is the mechanism how many people can contribute a small amount of money to create a huge fund to get people elected. The ANA has its own PAC. Now here's where it gets confusing. The ANA does not provide money to people running for office. The ANA gives money to their PAC, and the PAC gives money to people running for office. How many of you out there think that's kind of bogus? It's a loophole, and it tries to make people, but that's the way it is. Professional organizations do not support, or the ANA doesn't give money, doesn't lobby. It only encourages and endorses people based on their healthcare positions. Lobbying is the attempt to influence or sway a public official. The lobby can be face-to-face in writing. I mean, you can write a letter to your congressman. That's lobbying. Collective bargaining. Collective bargaining is a point of debate. A lot of nurses don't feel collective bargaining is appropriate for nurses, but some nurses believe that. And that's a very contentious opinion. It goes both ways. Collective bargaining, or unions, can be powerful. They're a strong force to help their people, but they cause division and a very adversarial relationship between the workers and the management. So that's the negative side of a union. There's also shared governance, which is non-traditional bargaining. So traditional bargaining, or unions, can bargain for the group. Shared governance or non-traditional bargaining does not have the same power of a union. It has power that is given to them from the management. So the manager say, you have a place at the table. You can help set rules. You can help create guidelines, but you can't bargain for a contract. It's less contentious. It's still working together, but it gives some power and authority to the nurses, which is very helpful in just helping everybody have a say in what goes on. It's frustrating to work someplace and have absolutely no authority and no voice in what's going on. So that is a very brief and rapid view of 3 learning plans, 1, 4, and 5, which is going to be on the quiz exam, quizam, I don't know what you want to call it, starting Monday. The 30 questions, you should plan that it'll take about 45 minutes, but it's an untimed test. You can take as long as you need. No rush. Do not rush. Read the question. Make sure you understand what the question is asking. Read the answers. Make sure you understand what the answers mean. And then choose the best answer. Don't read fast. So often I see people that make truly dumb choices because they didn't read the whole question, or they missed a word. So don't do that. Don't shoot yourself in the foot. Take the time, read the question, be thorough, and then choose the best answer. Once you make an answer, don't go back. Never change your answers, ever. I almost always see people change from the right answer to the wrong answer. If you're not sure about a question, skip it, come back to it. Make sure you go back to it, but skip it and move on. And again, you can bring a note card. You'll have to decide what goes on the note card. That's going to require your prioritization. All right, so we're at about 50 minutes right now. And obviously this is twice as long than I normally do, but I wanted to give you one video as a review for this test. I want to give you every possible chance of scoring good on this exam. You also, by now, after Learning Plan 5, have all the information you need to work on your paper. I'm going to do a separate video just talking a little bit more detail on the paper, okay? This is just test review. So, good luck. We'll see you tomorrow, or see you Monday. And if you have any questions, please email me. I will be checking my email through the week. However, starting Monday, if you have questions about content, don't know if I'm going to answer it, okay? Because the test has already started. And even though you can't email me from the test, I feel uncomfortable answering questions that are on that test once the test is open. Does that make sense? Guys, we're halfway through this class. Do you realize that? Halfway. And you're doing good. By the way, I'll get everything, all the grades. All the grades will be up to date by Monday morning for this class, so you'll see where you stand. Thanks a lot. Thanks for listening and watching, and I hope this helps. And again, reach out if you have questions. Take it easy. You're going to do great. I believe in every one of you. You've made it this far in the program. That proves to me that you know your stuff. I believe in you. I believe you can do good. Now you have to believe that you can do good. See you later. Bye.